Hi, this is Brian Kim. I'm going to share with you case number 259 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best way, but to get you to think critically of your technique so that you can refine and hone your technique so that you can provide the very best for your patient. So this patient is an Asian man, and he has a very strong Bell's reflex, dense cataract. And you're going to see the standard Lieberman speculum is just way too big for this Asian eye. This patient also has a high-powered lens. I haven't used the purple sleeve when I do this surgery, and you're going to see the use of this narrow wire speculum far better than the standard Lieberman. You can see this patient has a standard Lieberman. The patient has a strong Bell's reflex. I have very little exposure of the eye for the surgery, and so this standard Lieberman and an Asian eye is really terrible. And you can see both speculums side by side. The Lieberman is on the left, the narrow wire speculum is on the right. And you can see here, as I place this narrow wire speculum in this Asian eye, you'll just see the difference. I mean, it's so dramatic. I don't want to exaggerate, but it really is. It's so dramatic how much better exposure that I have with this narrow wire speculum for this Asian eye. So mind you that he does have a strong Bell's reflex, but you can see there's so much more exposure. And why is that? Because you're trying to expose the eye vertically, right? The superior and inferior lids. But if it's really wide, it really limits how much you can open it. It's basic geometry, right? The surface area that you're opening might be similar, but you're opening it in a different way and not the way you really need. You really need better superior and inferior exposure. And that's what this narrow wire speculum provides. So again, this patient does have a strong Bell's reflex, but you can see so much better exposure with this narrow wire speculum in this Asian eye. I'm using the cotton tip to help control the eye, and then I use the corneal marker, which will help me to center and size the rhexis. Again, he's having some trouble controlling the eye, but I'm using the cotton tip very carefully to turn the eye down. This is obviously the left eye. And I make my paracentesis incision on the right side. You want to make sure you're nice and flat, because if you're not flat, you're going to have premature entry, and that incision is likely to leak. Of course, the left side is much easier because the Bell's reflex is working with you. Injecting some intracameral epinephrine and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. This is the Orlock technique, where I twist the cannula within the incision and I'm able to control the eye and pull it down. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea. I'm losing a little bit of grip because of the patient's strong Bell's reflex, but I was able to do that successfully. Holding the eye still again with the Orlock technique, I place the microrhexis forceps in, puncture the center, pull down towards me, grabbing the right side of the tear, going around circumferentially, trying to match the rhexis size and centration to the corneal mark that I made earlier. I had to reposition the cannula because I'm losing a little bit of grip. And this patient is actively trying to look up throughout this entire maneuver as I'm doing the rhexis. Just very gently and in a very controlled manner. Continue the rhexis and then finish it off. Burp some viscoelastic out. You can see such a strong Bell's reflex. Putting some viscoelastic on the cornea. And this is the capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down. You can see I'm using the cannula to turn the eye downward, and that was intentional. I'm jiggling with the cannula, making sure I get a wave. Lift the lens up, decompress, and the lens begins to spin. And again, this is somewhat of a dense lens as well. So small Asian eye, narrow opening, use the narrow wire speculum, dense cataract, strong Bell's reflex. What else can I ask for? Perfect case. Lifting the incision with a chopper, go in with irrigation off to minimize decimase trauma. Again, this is a small eye, high powered lens, and that is why I'm using the purple sleeve. This is a 2.85 millimeter incision. Removing the surface epinuclear material, sliding the chopper under the rhexis edge. But I'd say, I don't know, I'm going to go ahead and just sculpt just to be on the safe side. So I go ahead and sculpt a little bit. I don't want to encounter a posterior plate. It is somewhat of a dense lens, so let's go ahead and debulk. And then switch to quadrant mode, sliding the chopper under the rhexis edge. Again, pronating my hand, leading off with the tip, making sure the tip is under the rhexis edge, so I'm within the bag. Sliding the chopper out to the lens equator, positioning the phaco tip deep, and I'm able to put it deep because I made a groove. Go ahead and crush and chop the terminal aspect of the lens, and that chop will propagate through and through, and this bypasses the posterior plate phenomenon. Sliding the chopper under the rhexis edge under the right heminucleus, hooking the peripheral lens, and now I've hooked the peripheral lens. You can see that the lens is up, and as I'm pulling it centrally towards the phaco tip is deep within the groove, and because it's deep, I'm able to crush the lens against the phaco tip, and that is the cross chop. Sliding the chopper around that first quadrant, the phaco tip is deep once again, crushing the lens with another cross chop maneuver, using the chopper to get around that fragment, pulling it up, crushing it, and then emulsifying it, loosening that piece with the chopper, teasing it up with the chopper, grabbing it with some vacuum, crushing it between the instruments, and then emulsifying the lens piece. Sliding the chopper around that second quadrant, hooking the lens, pulling it centrally toward the phaco tip, fracturing the lens again, using some vacuum to grab that piece, crushing it with the instruments, and then emulsifying it. Again, very systematic way of disassembling the lens. Placing the chopper around that fragment, crushing it against the phaco tip. It's nice and loose, and then go ahead and emulsify the lens piece. All right, that's the last piece on that. Turning the second heminucleus in front of me. Placing the chopper under the rhexis edge. The phaco tip is deep. Fracture the lens in half, bisecting it completely in half. Sliding the chopper under the third quadrant, hooking the peripheral lens and doing the same maneuver. Grabbing that free piece with some vacuum, crushing it between the instruments and then emulsifying the lens piece. Again, grabbing that fragment with some vacuum again, and then emulsifying it. Grabbing that fragment as well, crushing it, and then emulsifying it. And that's the last quadrant, sliding the chopper around the lens, hooking the peripheral lens, bringing it towards the center, crushing it in half, grabbing it with some vacuum, crushing it once again, and then emulsifying the rest of the lens pieces. Very easy, systematic lens disassembly of this dense lens in this Asian eye, high-powered lens, small eye, narrow opening, strong Bell's reflex. But again, very easy and systematic lens disassembly in this dense lens. Again, positioning the instruments around the lens pieces, crushing it, and then emulsifying it. I don't really have to go through all that effort, but I do that as a habit because then when things get really challenging, I don't have to rethink and redo my technique. Since I do it like this all the time, I'm always mindfully mitigating risk by utilizing less ultrasonic energy and vacuum as I'm disassembling the lens. Using some vacuum to grab the epinuclear pieces now. You can see it's rather thick, the epinuclear pieces. I'm utilizing vacuum to remove those pieces very slowly, keeping that chopper deep to protect the posterior capsule. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start sub-incisionally, peeling the cortex from anterior to posterior. By doing it this way, I get the cleanest removal of the cortex and the most efficient removal of the cortex. Switch to polish mode, polishing the posterior capsule, polishing under the rhexis edge of the lens epithelial cells. Pulsing BSS into the subincisional capsule fornix. There's some material right there on the right side, so that was good. I was able to get rid of that stuff. Disengaging the fluid, pushing cohesive viscoelastic to fill the bag. You can see as soon as I let go, the eye goes right back up. So again, he's maintaining that strong Bell's reflex. Polishing under the rhexis edge, first on the left side and then the right side. Sweeping and removing the lens epithelial cells. Again, this patient's looking up. It's a little bit harder to sweep on that right side, but I manage. So as I said, high-powered lens. I'm using the sweeper now as an Orlock to try to turn the eye down a little bit. And this is a 3-piece lens. When you're dealing with dense lenses, I'm always wanting to put 3-piece lenses because, again, it's been my experience that they tend to have some zonulopathy. Go ahead and place the leading haptic into the bag, as well as the optic. The trailing haptic is going to be left out. I'll dial it into the bag with the Maltzman. Go in with irrigation off, activate irrigation. Getting underneath the lens, removing all the viscoelastic from within the bag, removing all the viscoelastic from the anterior chamber, and then I will hydrate my incision. So again, this patient is an Asian patient, small eye, high-powered lens, dense cataract, strong Bell's reflex. I put the standard Lieberman. You saw how big that was. And again, it's basic geometry. Like I said, when you try to open the eyelid, you can open up in different ways. But remember, it's just all geometry. If you have a big Lieberman speculum that's very wide and you have a small eye, you're going to limit how much the speculum opens. You're kind of really restricting yourself. But if you have a narrow wire speculum, the part that's opening is rather narrow, and you can retract a lot more efficiently vertically. And so you can see when I place that narrow wire speculum, how much better exposure I have to do the surgery. And again, I love this narrow wire speculum and I use it all the time now. It's not just for Asian eyes, it's for other eyes too, deep set eyes, small eyes. But a lot of Asians do have smaller eyes, and so it's very advantageous in this situation. And you saw this patient has a very strong Bell's reflex, and I use the Orlock technique to turn the eye down so that I can do the surgery throughout the case. I use that cannula, the viscoelastic cannula, very efficiently to be able to control the eye to do the surgery. And then I performed terminal chop, cross chop, leveraging mechanical fracturing to disassemble the lens, fracturing the lens with mechanical forces, utilizing less ultrasonic energy and vacuum, reducing CDE and reducing corneal endothelial damage in the process. And so this patient did very well and saw well post-op day 1 with a nice clear cornea. Again, any patient who has a small eye or an Asian eye, I would strongly encourage you to consider getting the narrow wire speculum. It really is just a no-brainer. I don't know why throughout my training I was never exposed to this speculum, but it really is a game changer for these eyes. So I hope this was helpful to you, and I thank you for your attention.